This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Welcome and thank you for joining us. Respiratory System, Part 1.
Hello, my name is Tim. Welcome to 24/7nursetutors.com. Are you ready to discuss the respiratory system? Let's review the upper respiratory tract infections and inflammatory disorders. Allergic rhinitis. It's also called hay fever. You know how it is when your classmate who is sitting next to you begins to sneeze a lot. What do? You move, don't you? You're thinking, whatever he has, I don't want. I better move. Yeah, this could be allergic rhinitis. If your nose is often runny or stuffy, or if your eyes, mouth, or skin often feels itchy and you sneeze a lot, you may well have allergic rhinitis. Allergic rhinitis takes two different forms. There's seasonal, and those symptoms of seasonal allergic rhinitis can occur in spring, summer, and early fall. They are usually caused by allergic sensitivity to airborne mold spores or to pollens from grass, trees, and weeds. Perennial, well, people with perennial allergic rhinitis experience symptoms year-round. It is generally caused by dust mites, pet hair, or dander, cockroaches, or mold. Underlying or hidden food allergies rarely cause perennial nasal syndromes. Rhinitis, on the other hand, is the common cold and is basically irritation and swelling of the mucous membrane in the nose. Sinusitis is inflammation of the sinuses. Did you know this runs in families? I know a family, almost every member of this family has sinusitis. They complain of poor sense of smell, thick nasal mucus, a plugged nose, and pain in the face. With acute sinusitis, we see fever, headaches, sore throat, and a cough which is often worse at night. Pharyngitis refers to inflammation of the structures of the pharynx. The tonsils are most often affected. There are two types, viral and bacterial pharyngitis. With viral pharyngitis, there's usually a mild cold symptom. With streptococcal pharyngitis, it's assessed with a throat culture or a rapid strep test. A rapid strep test is pretty easy to do. The patient's throat is first swabbed to collect a sample of mucus. The sample is then applied to a strip and tested to see if group A streptococci antiagents are present. Pharyngitis may be accompanied by a sandpaper rash, petechiae, abdominal pain, vomiting, and is rarely accompanied by cold symptoms. If left untreated, it may result in rheumatic fever or acute glomerulonephritis. Tonsillitis is an infection and inflammation of the palatine tonsils. Signs and symptoms include sore throat, drooling, fever. Most common cause is group A beta-hemolytic streptococcus, usually treated with amoxicillin. If the strep is negative, it is assumed to be viral and treated with comfort measures. For NCLEX, you do want to know about a tonsillectomy, even though it is less common nowadays. Usually done for 3 or more cases of strep throat in 6 months, for mouth breathing or sleep apnea. The risk for hemorrhage is greater because the site is cauterized and not sutured. The risk for bleeding is high during the first 24 hours and 7 to 8 days post-op. Observe closely for frequent swallowing, changes in blood pressure, and don't allow red foods or drinks to be consumed. Laryngitis is an inflammation of, guess what? You got it, the larynx. It often occurs as a result of voice abuse or exposure to dust, chemicals, smoke, or other pollutants. Common in winter and easily transmitted, the cause of infection is almost always a virus. Your patient may present with hoarseness or aphonia and a severe cough. As a nurse, you'll encourage your patient to rest their voice and avoid smoking. Inhale cool steam or an aerosol. Maintain a well-humidified environment. Maintain daily fluid intakes. Sometimes antibiotics like amoxicillin may be needed if it is bacterial. The next topic in your book is bronchoscopy. What is a bronchoscopy and what is it used for? A bronchoscopy is a visualization of the tracheobronchial tree via a scope advanced through the mouth or nose into the bronchi. This is done using a fiber optic tube, a bronchoscope, a thin, flexible fiber optic telescope. This is done to remove foreign bodies, secretions, or to obtain specimens of tissue or mucus for further study. Now, as a nurse, please remember to obtain an informed consent before the procedure. If you are the PACU, make sure there is an informed consent on file. The patient needs to be NPO for 6 to 8 hours before the procedure. You must administer ordered procedure medication, like Valium, to produce sedation and decrease anxiety. You should also inform the client to expect some soreness, dysphagia, and hemoptysis after the procedure. Advise the client to avoid coughing or clearing their throat. Observe for signs of hemorrhage and/or respiratory distress. Keep the head of the bed elevated. Monitor vital signs until they're stable, and do not allow fluids until the gag reflex returns. For NCLEX, you need to know post-op care and also how to identify potentially serious situations. For post-op care, keep the patient NPO until the gag reflex and monitor laryngeal edema. I will repeat that. Monitor for laryngeal edema. How do you do that? What are you looking for with laryngeal edema? Inflammation, fever, malaise, dysphagia, hoarseness, and throat pain. Hey, just look at the picture. They're putting the scope down. So our highest priority, airway. Keep the head of the bed elevated and keep the patient comfortable. Monitor for hemorrhage and pneumothorax. The endoscope is inserted through the nose or mouth, then through the trachea, and finally into the bronchial tubes. During the examination, it is possible, without the patient feeling anything, to extract secretions for analysis of bacteria. Additionally, it's possible to take small tissue samples with biopsy forceps. During the examination, the patient will receive a sedative. During post-op, the patient needs to remain NPO for 6 to 12 hours until the gag reflex returns. Monitor for pharyngeal edema, hemorrhage, and pneumothorax. Keep the head of the bed elevated. One type of lung collapse, known medically as pneumothorax, occurs when air leaks into the area between your lungs and chest wall, the pleural space. The pressure of the air against the lung causes it to give way, often leading to mild to severe chest pain and shortness of breath. A pneumothorax can be caused by a chest injury, certain medical treatments, lung disease, or a break in an air blister on the lung surface. A lung collapse is proportional to the amount of air that leaks into your chest cavity. Although the entire lung can collapse, a partial collapse is much more common. A small, uncomplicated pneumothorax may heal on its own in a week or two, but when the pneumothorax is severe, the excess air is usually removed by inserting a tube or needle between the ribs into the pleural space. If air continues to build up, the increasing pressure can push your heart and blood vessels toward the uncollapsed lung, compressing both your lung and chest. Called a tension pneumothorax, this condition is life-threatening and requires immediate medical care. The next topic is sputum specimen. A sputum specimen is needed to diagnose bacterial infection, to assess presence of abnormal cells, and identify organisms growing in the sputum, to evaluate the treatment and the acid-fast bacillus stains. There are 3 major types of sputum specimen: culture and sensitivity. Gram stains examples are acid-fast bacilla. We usually do 3 consecutive into the early AM. And cytology. This test is to identify abnormal lung cancer by cell type. 3 is usually done early in the morning. Remember, as a nurse, you are the one who will instruct your patient on what to do. How do we get a good specimen? Well, the first thing in the morning when they get up, they brush their teeth and rinse their mouth with water. No mouthwash, please. I repeat, no mouthwash. Tell them to take a very deep breath and hold the air for 5 seconds. Then slowly breathe out. Take another deep breath and cough hard until some sputum comes up into the mouth. Spit the sputum into the sterile cup. Keep coughing up sputum until you have at least 5 milliliters. Remember, we need sputum from deep within the lungs, not saliva. How do you know the difference between saliva and sputum from the lungs? Well, sputum from the lungs is usually thick and sticky, while saliva comes from your mouth and is very watery and thin. Let's discuss a pleural effusion. Pleural effusion is an excessive buildup of fluid in the pleural space. What is the pleural space? Well, the pleural space is the space between your lungs and chest cavity. It is the space between the visceral and parietal pleura. There's always a small amount of fluid in the pleural space to help lubricate the lungs as they expand within the chest during breathing. Did you know a study by Yale University doctors showed that 15% of hospitalized patients who are diagnosed with a pleural effusion die within 30 days? Yes, 15% of hospitalized patients who are diagnosed with a pleural effusion die within 30 days. Now that's crazy, and it's scary. That is why, as a nurse, it is important for you to monitor your patients closely. Effusions can be treated with thoracentesis, pleurodesis, chest tubes, surgical pleurectomy with a catheter insertion, or a pleuroperitoneal shunt. Thoracentesis is, of course, the removal of fluid for analysis and to reduce shortness of breath or discomfort. The nurse's role is to prepare and position the client over the table, side lying. Pain management is important, and frequent repositioning and ambulation to facilitate drainage. We'll go into a bit more detail about thoracentesis on the next page. Pleurodesis is chemically done to obliterate the pleural space and prevent reaccumulation of fluid, performed via thoracoscopic approach or a chest tube. Bleomycin and tetracycline is normally instilled in the chest tube, clamped off for 60 to 70 minutes, and the patient assumes various positions to promote uniform distribution. With chest tubes, well, we'll discuss chest tubes in more detail in the lecture because you will always come across chest tubes at work. A pleurectomy is the removal of a portion of the pleura. This is usually done in a patient who has cancer. A pleuroperitoneal shunt is done when 2 catheters are connected by a pump chamber with 2 one-way valves. A surgically implanted catheter for transport of fluid from a pleural space into the peritoneal cavity where it is absorbed. It is used mainly for treatment of malignant pleural effusions. What is thoracentesis? Well, thoracentesis is a diagnostic procedure done in patients who have abnormal amounts of fluid accumulation in the pleural space. It is the removal of blood, fluid, or air from the pleural space performed for diagnostic purposes or to alleviate respiratory distress. A needle biopsy of the pleura may also be done. The needle is placed through the chest wall into the pleural space, and fluid is then withdrawn into a syringe. There are 3 different positions we can put the patient in for this procedure. Sitting on the side of the bed over the bedside table, chest elevated, lying on an affected side, or straddling a chair. How much fluid is usually removed during thoracentesis? And what is too much? Well, no more than 1,000 milliliters of fluid should be removed at this time. Why do you think the doctor should not remove more than 1,000 milliliters of fluid? Because it may result in a sudden fluid shift, pulmonary edema. Fluid withdrawn should be sent to the lab for culture and sensitivity, analysis of glucose, protein, and pH. Complications include pneumothorax from trauma to the lung and pulmonary edema resulting from sudden fluid shifts. As a nurse, make sure you obtain an informed consent. Ensure a chest x-ray is done before and after the procedure. This is to check for pneumothorax. Support the client in the sitting position. Inform the client not to cough during the procedure to prevent trauma to the lungs. Assess pulse and respirations before, during, and after the procedure. And obtain a specimen of the pleural fluid for diagnosis. Remember, thoracentesis is not a permanent solution. Fluid may reaccumulate after a few days. This will temporarily relieve symptoms, and potential complications include bleeding, infection, and pneumothorax. Pneumothorax is a condition in which air gets in between the pleural space, between the lungs and chest wall. Pneumothorax is a serious, sometimes life-threatening condition. Normally, two thin layers of tissue, the pleura, separate your lungs and chest wall. Any air that leaks through lung tissue into the pleural space will cause the lung tissue to collapse in proportion to the amount of air that enters the pleural cavity. Air can collect in the pleural space for many reasons, including an injury that damages the chest wall, such as a stab or gunshot wound, a broken rib that punctures the lung, a procedure or surgery that involves the lung or chest wall, spontaneous pneumothorax, which is thought to be due to the rupture of an air-filled blister on the surface of the lung. And people with underlying lung disease, such as asthma or cystic fibrosis, may be at increased risk of a pneumothorax. Signs and symptoms of pneumothorax include sudden sharp chest pain, shortness of breath, chest tightness, a diagnosis of pneumothorax by chest x-ray, and occasionally the air leak seals itself. If air continues to enter the pleural space, a tension pneumothorax occurs. The large amount of air may push the mediastinum, which is the center of the chest, toward the other lung, compressing it. This is life-threatening and requires immediate insertion of a chest tube between the ribs to relieve the increased pressure. Let's briefly talk about tension pneumothorax. Look at the picture in the video. A tension pneumothorax is when air, blood, or fluid rapidly enters the pleural space and is unable to escape. The lung collapses, and it is a medical emergency. What we see is an increase in intrapleural pressure, compression of the lung to the other side. This compresses against the trachea, the heart, the aorta, and the esophagus. Ventilation and cardiac output are greatly compromised. Think about this for a bit. If the air keeps on compressing against the trachea, heart, aorta, and esophagus, what do you think will happen after a while? What will we see when the pressure has pushed the trachea, heart, aorta, esophagus to the other side of the chest? Well, we'll see severe dyspnea, tracheal deviation, decreased cardiac output, distended neck veins. We will see signs and symptoms of shock. The respiratory rate and pulse will go up, and the blood pressure will go down. Hey, this is a medical emergency. Now, how is tension pneumothorax treated? With an emergent needle decompression. Now, as a nurse, you may have to help a physician with an emergent needle decompression. A large bore needle with a catheter of usually about 14 gauge to 16 gauge is inserted into the second intercostal space. They normally use a 3 to 6 centimeter long needle. Once the needle is in the pleural space, guess what we are going to hear? Right, we're going to hear a hissing sound of air escaping. And I'm sure that patient will turn around to the doc and say, "Thank you, I can breathe better now." Right? The pulmonary function tests are usually performed by the respiratory therapist to evaluate lung function. This test uses a fancy spirometer. The client blows hard, fast, and as long as possible into the mouthpiece. Then rest is provided after the procedure. No bronchodilators are given for 6 hours prior to the procedure. Pulmonary function tests provide one measure of how well controlled a patient's asthma is. Let's discuss adventitious breath sounds. Fine crackles, dry, high-pitched popping. Examples are chronic obstructive pulmonary disease, congestive heart failure, and pneumonia. Coarse crackles, moist, low-pitching gurgling are examples of pneumonia, edema, and bronchitis. Sonorous wheezes, low-pitched snoring, are examples of asthma and bronchitis. Let's discuss adventitious breath sounds. Sibilant wheezes. These are high-pitched musical sounds. Examples are asthma, bronchitis, emphysema, possibly a tumor. Pleural friction rub. This is a cracking, grating sound. Examples are pleurisy, tuberculosis, an abscess, or pneumonia. Stridor. These are crowning sounds. Examples are a croup, a foreign body obstruction, or a large airway tumor. Let's discuss lung sounds. Resonance. This is low-pitched sounds heard over normal lungs. Hyperresonance. These are loud but lower-pitched sounds than normal resonance heard over hyperinflated lungs, such as in chronic obstructive lung disease or acute asthma. Timpani. Well, timpani is drum-like. They're loud. They're empty quality. They're heard over gas-filled stomach or intestine or pneumothorax. Dull, medium intensity pitch, and the duration heard over areas of mixed solid and lung tissue, such as over the top area of the liver, particularly consolidated lung tissue like pneumonia or fluid-filled pleural spaces. And flat. These are soft, high-pitched sounds. Short duration. They're heard over very dense tissue where air is not present. Remember, you are more than a conqueror and you will be successful. Join me as we review core content in the next unit.